that
Carry on.
Fertilizer or water contaminating animal feces, and then the drug resistant bacteria then lands into the food crops. Again, we eat the food, and that way we also then develop antibiotic resistance, then spread from human to human. Next slide, please. Now the CDC has released the first antimicrobial resistant report that looked at the burden and threats to the human health posed by antibiotic resistance in the US. And this was in 2013. So that was in 2014, there was a news headline that said the rise in antibiotic resistant bacteria could lead to a future full of untreatable infections. And these experts have warned us about this for years. By 2020, the Obama administration then said, this is the 10-year plan, that they should establish antimicrobial stewardship programs in all acute care hospitals and improve antimicrobial stewardship across all healthcare settings. Reduction of inappropriate antibiotic use by 50% in outpatient settings and by 20% in inpatient settings. Elimination, getting rid of the use of medically important antibiotics for growth promotion in food producing animals. Now, as the population was booming, and so nations, governments around the world used these antibiotics to enhance growth in either crops or in animals. But this, as you can see, created other problems. So antibiotic resistance is a worldwide problem. 23,000 people die and 2 million become sick each year because of antibiotic resistant infections. That was said by Friedman. And these infections are estimated to cost 20 billion in direct health costs, far more lost in productivity. So as you can see, this is a global issue. So this was brought up at the CDC in 2013. Next slide, please. The Joint Commission International then came along in 2017, and they supported the development of antimicrobial stewardship. They then have a standard for hospitals, critical care access hospitals, nursing care centers, that all hospitals that will qualify for accreditation by the JCI, Joint Commission International, effective January 1st, that we should all have an antimicrobial stewardship program that is active in the hospitals. Next slide. In 2019, the World Health Organization, WHO, as we would say, released a aware classification antibiotics. And how this works is there's different types of antibiotics is then classified in access, watch, and reserve. Now the access examples is like your amikacin, your gentamicin, and this group is either IV or PO. This group includes antibiotics that have activity against a wide range of commonly encountered pathogens, while also showing a lower resistance. The watch group is azithromycin, ciprofloxacin. This group has a higher resistance potential. So this group, we really need to watch out. And this is for selective. You have to be selective on which bacteria this will be prescribed for. These medications should be prioritized as key targets of stewardship programs and monitoring. Then we have the WHS, then have also a reserve group, colistin. This group includes antibiotics and antibiotic classes that should be reserved for treatment of confirmed or suspected infections due to multi-drug resistant organisms. And this group should be treated as the last resort options. And if you just think back on your own clinical experience, and just think of whether sometimes we have the group that is under reserve might be used as the first line of antibiotics, which is a problem. It can create multi-drug resistance. Next slide. Sabahi then had a national antimicrobial stewardship program in Saudi Arabia. In the future, they came up with a statement in 2017 that said that the program must expand in the coming years to cover all MOH government institutions and private sectors, would properly get all the application advantages to decrease the resistant pattern of the organisms, antibiotic usage, and saving of additional cost. And all of these bodies have now come out and voiced their concern about antibiotic resistance. Next slide. Next slide. So is this evidence-based? I'm talking here about the nurse's role in antimicrobial resistance program. So many papers has been published by nurses. They're reconsidering the nurse's role in antimicrobial stewardship, improving antibiotic stewardship by involving nurses, keeping patients safe, antibiotic resistant, and the role of nurse executives, and defining a role of nurse education in staff nurse participation. Now, if anyone wants to argue the point is, where does the nurse fit in this stewardship program? If you look at the slide, we have the patient and family, then we have the nurse, then we have the infectious disease, we have the administration, we have pharmacy, we have a microbiologist, we have the infection control practitioners, we have case managers, and then we have also the hospital organization. So if we look at this graph, it's the nurse is patient and family first, then the nurse, and all these other entities play a role to, including the nurse, to reduce antimicrobial resistance. Next slide, please. So let's look at the antimicrobial stewardship functions performed by nurses. So first of all, there should be appropriate triage and isolation. And the accountability drug experts education, this is what's written in the papers, they should do it, the ICPs. But in fact, the nurses initially assess the source of infection. We identify appropriate precautions, and then consultation may come subsequently from the infection preventionists. Accurate antibiotic allergy history. I know in some countries, nurses do not take antibiotic allergy histories. The literature says it should be a pharmacist. The nurse takes the allergy history, performs medication reconciliation, and we also report this in the medical record. Early and appropriate cultures. Literature says it should be done by microbiologists. In fact, the nurse obtains the cultures before starting antibiotics. We send the cultures to microbiology. The nurse monitors the cultures results and reports the results to the physician. Timely antibiotic initiation. Literature says it should be the hospital infectious disease specialist or preventionist. Antibiotic initiation, the nurse receives the orders. We reviews the dose, the time for accuracy, checks for allergy, and administers and records the antibiotics. Next slide. Clinical progress and patient safety monitoring. Maha, you're too fast for me. Can you go back, please? Back again. Another slide, Maha. Thank you. So clinical progress and patient safety monitoring, progress reporting. Who does report on the patient's progress on the patient, how the patient does with the antibiotics, what's happening with the patient. Literature says it should be a hospital infectious disease specialist, but as nurses, nurse cares for the patient 24/7. That monitor and communicate daily patient progress. The adjustment of antibiotics, again, the literature says it should be a hospital infectious disease specialist, but in reality, laboratory and radiology reports are chased by the nurse, the bedside nurse. They chase for the results, they coordinate these results and communicate it to the treating physician. Antibiotic dosing, culture and sensitivity reporting and de-escalation. Again, literature says it should be infectious disease specialist. In reality, the nurse updates clinical and laboratory renal function results, drug levels, and preliminary or final microbiology results. We communicate that to the physician. Adverse events, hospitalist pharmacists is the ones that's supposed to do this according to literature, but the nurse monitors, because like I said previously, the nurse cares for the patient 24/7. So the nurse monitors and reports to the physician any adverse events, including diarrhea, that the patient might have when starting a new antibiotic. Next slide, please. During discharge, are we involved in antibiotics administration, antimicrobial stewardship programs? The nurse, where's the nurse fit into this whole process? So the transition from IV to PO antibiotics for our outpatient, when the patient is going to leave the hospital, literature says it should be the case management, infectious disease specialist, or the pharmacist. The nurse monitors clinical progress and the patient's capacity to take oral medication. So when they move from IV to PO, we should actually ensure that the patient is able to either swallow these medications, so there's no side effects. So length of stay, again, the case management or infectious disease specialist is the ones, according to literature, that looks at the patient's length of stay. When we look at the hospitals, the nurse is the one that monitors the patients 24/7. We nurses advocate for patients and inform physician about their condition. Patient education and medication reconciliation. Again, the nurse continuously educates the patient and family and performs discharge teaching, how to take the medication, when to take it, before meals, after meals, and all of that. The nurse is actively involved in that. And then outpatient visiting nurse. Again, the nurse there communicates the patient's diagnosis, the management, and medications to the nurse at their home health care, like we would have in our setting, and explaining them to them what the patient is on. So as nurses, we look at all of this and say, how can we do this? Where do we fit into this whole scheme of things? Next slide, please. Now, there's been identified or perceived barriers that we as that nurses has come up with and said nurses are not able to do this role or be involved in the antimicrobial stewardship program for a lot of reasons. Perceived barriers. Number one is nurses said increased workload of nurses. I said that is too much work. We cannot still take that on. And they came out with to say that we have to develop an intervention that can be easily integrated into the existing scope of practice and workflow. Frontline nurses need to be involved. We need to seek their feedback before implementing any change. Provide scripts or develop algorithms to assist nurses in performing antibiotic functions more efficiently, and then develop patient educational material to facilitate conversation with nurses. Nurses also said in this paper that lack of physician support, Doctors do not support when nurses actually give their input. So the recruit nurse and physician leaders will minimize this to discuss the key roles played in antimicrobial stewardship, ensure buy-in from unit leadership, invite nurses to be part of the ASP committee. The other barrier that was identified is that as nurses, they identified that they have limited knowledge. These knowledge gaps needs to be identified, root cause analysis, focus groups, we can have case reviews, and education should be written in the nurses' language, customized education to nurses regarding antibiotics. Next slide, please. Lack of experience or confidence. How can we overcome this? Every unit can identify a unit champion with interest in the topic to serve as a liaison between the bedside nurse and the antibiotic stewardship program. Share examples of previously successful nurse-led interventions that has occurred both in your institution as well as in the literature. Identify processes typically held by nurses during handoffs, transition in care, where antibiotic information can be discussed. Debriefings, this is where antibiotic information can be discussed as well. Nurses also in this paper say that nurses' input is not valued. How can this be overcome? This barrier, actively provide input during rounding processes. Accept the problem with your vascular devices, your IV access, difficulties, the patient's difficulties taking medication by mouth, if there's any concerns from the family. So nurses should be encouraged to talk about antibiotics and the related issues during the multidisciplinary rounds. Utilize tools to facilitate bedside nurses' communication to providers by using the SBAR tool. SBAR tool is situation, background, assessment, and recommendation. And nurses should be empowered to be able to give recommendations on any issues that the patient encounters, specifically regarding antibiotics. The hierarchical perception must be dampened through huddles or inviting questions. Clear and explicit support for nurses' role in antibiotic stewardship should be expressed by clinical leaders. So there should be buy-in from the clinical leaders. As I said previously, that the nurse is 24/7 with the patient, and they have a role to play. And next slide, please. And that's the end of my slide. Now it's open for any questions that you have.
Thank you so much, John. So you guys can ask either by raising your hands to make a comment or question for John, or by asking me to unmute you so you can ask your question verbally. Or you also can use the chat box to write down your questions. Okay, Ms. Samira, I will unmute, so please go ahead and ask your question.
Good evening, everyone. Good evening, Janet. Thank you for this very nice presentation. It was really informative talk. My question is about now the nurses, they implement all the rule in antibiotic program that include taking the culture, choosing the report, monitor the patient progress. And this, it seems like they replaced all the specialists that they should implement their role by their qualification and experience. How does this will affect the accuracy of the patient outcome and the patient care when the nurses replace, everyone in the planet?
Thank you very much for your question. Let me just recap. You say, how does this affect accuracy if nurses replace everybody's role? In the literature, it actually stipulates that infectious disease personnel should do certain roles. But if we look in reality, we are with the patient 24/7. So it's by default. It's not that we want to, but this is the nurse's role. We administer antibiotics. We do the blood cultures. We've been trained to do blood cultures before we give antibiotics. We follow up the results because we care about the patient and we care about the patient getting treatment at the right time and stuff like that. So I don't think it's something new that we're doing. We've been doing this, and it's just by time that it's been acknowledged that the nurse, this is the nurse's role in the Antimicrobial Stewardship Program. Did I answer your question? Hello?
Thank you so much, John. I think Miss Samira is on mute. I can't see if she's on mute or not. There is another person who raised a hand. Okay. Let me see. I do have a question for you, John, while other attendees preparing their questions. So my question is, how do you see the culture, the healthcare provider culture for empowering nurses to take an active role in the stewardship program? How does nurses themselves perceive their role in a stewardship program?
Thank you, Mars. It's an excellent question. As in the paper that I presented during the slides, is that this perceived barriers is from nurses. The first thing nurses say, it's an increased workload. This is extra stuff that I'm doing. I just want to be at the bedside, take care of the patient, but now I have to be involved in the antimicrobial stewardship. So how do we change this culture? Is by involving the frontline workers and empowering them and letting them know you're already doing it. It's just got a name now. So it's not something new. You do take cultures. You've been taught in nursing 101 how to do blood cultures, how to administer antibiotics. Pharmacology is taught in nursing schools. So it's not something different, but this is a coordinated program where we have to work hand in hand with the infectious disease practitioners, with our infection control practitioners, with our physicians and microbiologists to actually give the patient the best outcome. Ms. Maha, did I answer your question?
Yes, you did actually, indeed. So the aim of this talk is just to open your eyes as a clinician that your role in antimicrobial stewardship is huge. And since you are the direct care provider 24/7, you're actually going to play a major role as a patient advocate in terms of practicing and managing patients with antimicrobial agents. So this is really important for us as a critical care nurses. We have another question from Ms. Fatima. Go ahead, Fatima, unmute yourself and start your.
Good evening, everyone. Thank you, John, for the presentation. Actually, what I have is a comment, and it could be an extension of the nurses' role in stewardship program. Actually, we do it as nurses all the time, starting from prevention, because this is what we need to think of. To prevent antimicrobial resistance, we need in the first place to prevent infection, which we do it all the time by hand hygiene, adhering to infection control practices. Also very important to highlight the timely administration of antibiotics. That's why we focus a lot on this part. But what I think that we need to focus on more is proper culture collection, because yes, we do our best to send cultures on time, but what about the technique? Because we take the culture, but sometimes it's contaminated and the lab requests to send another culture, which unfortunately delay proper management and delay the identification of the causative agents. So I think this is something we need to focus on, proper culture collection for the nurses.
Excellent.
Thank you, Fatima. Yeah, thank you, Fatima. That's a really excellent point, that antimicrobial resistance prevention starts with hand hygiene, something simple as hand hygiene. And yes, proper culture, we need to look at the technique, and because that does impact, and like you mentioned, it delays treatment, timely treatment. So yeah, this is something that we need to look at.
I see Ms. Samira is raising her hand again. Unmute yourself and go ahead with your question.
Yes, thank you, Janet. You answered my first question, but I was not able to say thank you very much. The second question is already raised by Fatma, that's an appropriate culture, but how, during this program, did you establish or initiate any auditing tool to make sure that the nurses follow the same standard during this program, and all the nurses being educated in the same way, implement the same process? How do you ensure the process is go as what should be in this program?
So basically, I'll start off by saying in National Guard, we have a procedure that has actually been rolled out by the nursing education to all nurses. Then the CRN will then train the trainer, but we also have a lead a program, Learn Sepsis, Teach Sepsis, where it is our nurses on the floor, and they do come to this program, and we have clinical stations where nurses are, again, this is reiterated, the importance of the proper technique and how to actually when to give the antibiotics and where to get, they get a demonstration and they do a re-demonstration. But ultimately, it is in the clinician's responsibility to practice what we've taught them, and also the clinical leadership on the wards to ensure that these techniques are followed. If we, for instance, collect data, get data that we have so many contaminated samples, then we should look into practice issues. And that should be fixed in by the clinical leadership.
Thanks, John. If you allow me, guys, I just have one comment related to nurses' role in the stewardship program. And I think this is related to renewal of antibiotic. Nurses get used to asking physician, this medication is due for renewal. Would you mind please to renew this antibiotic? Would you mind? And instead of asking, would you mind please to renew this antibiotic? Ask, would you mind please review if we still need this antibiotic? Because the key to reduce resistance is narrowing the choices based on culture and sensitivity. So if your patient in a wide spectrum antimicrobial agent, to treat him from cases that are time sensitive like sepsis, after you get your culture and sensitivity, you need to work with the team, the clinical pharmacist and the physician to narrow the options of antimicrobial treatment and go to the medication that are sensitive to that specific microbes.
Excellent point, Maha. Thank you very much.
Any further questions or comment? Okay. I don't see any further questions or hands that are up. I really appreciate your patience with us, that we delayed you for about 30 minutes. It's a pure technical issues and it takes really long time to fix it. I'm really honored that lots of you have the patience and the courage to wait with us and to take their own time to learn and listen to the presentation from John. I hope, inshallah, that you learn something that is beneficial for your daily clinical practice, and you're taking some of these ideas to your hospital if you already don't have an established program for antimicrobial stewardship. You can raise these ideas within your organization, and believe me, it's not only budget, it's not only time and effort, but it's patient life that have a significant improvement when organizations start to utilize antimicrobial agent wisely. Thank you so much. I do have one comment from Mr. Ahmed. You can unmute yourself and go ahead with your question. Yes, Ella, sorry, Ella Ahmed, go ahead.
I just wanted to say, I was just asking you, what is this meeting about again?
Antimicrobial stewardship and the nurse's role in the program.
I'm not sure if he's in the right channel. So, because the question is not absolutely relevant to the topic, so I think we reached to conclusion. Have a great evening, everyone, and we'll see you in our next webinar, inshallah. Thank you so much.
Thank you, everybody.